Noswaith dda iawn I chi, blwyddyn newydd dda I chi, a chroeso cynnes I chi. Good evening and welcome. Happy New Year to you if mid-January is not too late to wish you that. Wi'n hynod falch fod cyment wedi ymuno ni hyn o'i glywed am a thrafod pwnc sydd yn amlwg o gryn bwys a chryn ddiddordeb I gynifer. Some quick housekeeping first of all. This evening's digital showcase will be recorded as you've just seen on screen, and we'll send you the link to the recording following. My name is Professor Damien Walford-Davies. I'm Deputy Vice-Chancellor of Cardiff University, and I want to first thank our alumni, our staff, donors, friends, and supporters for joining us. Now, you're here this evening as part of an international Cardiff community and much valued ecology, if I can put it that way, comprising graduates and friends who continue to support the learning and research done right across the university. Cryn diolch yn ddidwyll iawn I chi am barhau I wneud hynny. Okay, this evening's event shines a light on research taking place here in Cardiff University on Polycystic Ovary Syndrome, PCOS. And as so many of you know, and know personally, the condition is thought to affect around 1 in 10 women in the UK, according to the NHS, and it can affect the way a woman's ovaries function, resulting in fertility problems, and indeed other significant conditions. And as I said earlier, it's clearly a condition that commands our interest, our attention, our sensitive understanding, and our active medical efforts. And this evening is about all of those things. I'm delighted to introduce our speaker, my colleague, Professor Aled Rees, Professor of Endocrinology from the Neuroscience and Mental Health Research Institute here in Cardiff University. And I'll say a few words about Aled, who's just appeared on screen. He has an established track record of clinical and translational research in multiple aspects of endocrinology. As you know, the science and study of the endocrine system and its specific secretions, known to us more familiarly as hormones. And he has a particular interest in neuroendocrinology, the study that is of the effect of those hormones on the nervous system, including the brain. Aled, we are very proud to say, is homegrown talent, having qualified in medicine at Cardiff and having been awarded his doctorate here as well. Gwych yw medru cydnabod y berthynas hirhoedlog honno sydd gan Aled a'r Brifysgol. So again, some quick housekeeping and logistics before I give the stage to Aled. We'll hear from Aled shortly. Following his talk, there'll be an opportunity for the audience to ask questions. And if you do have any questions, please enter them at the Q&A box at the bottom of your screen at any point, and we'll get to as many questions as time allows. Okay, that's enough from me. Aled, croeso cynnes I ti, a warm welcome. Over to you.
Well, diolch yn fawr iawn, Damien, am y geiriau yna. Thank you very much indeed, Damien, for that very kind introduction. And many thanks indeed, in fact, to the organisers of the event for inviting me along this evening for an opportunity to inform you about some of the work that we've been undertaking over the last few years, indeed, on PCOS, or Polycystic Ovary Syndrome, particularly in relation to the long-term health aspects of the condition. It's my real pleasure to be able to share this with you this evening. I should draw your attention that I will be sharing occasional medical images, and I hope that's okay with the audience. So I'll start off by reminding everybody what PCOS is. PCOS, or Polycystic Ovary Syndrome, is in fact the commonest hormonal disorder affecting young women, with estimates of some 5 to 13% of the premenopausal population affected at some stage during their lives. It was originally described as long ago as 1935 as a triad or a combination of polycystic ovaries, as we can see in the top right of this slide, from an ultrasound scan. Hirsutism, which in medical terms we mean by hair growth in the male pattern, as shown in the cartoon on the bottom right, with the typical affected areas, including the chin, top lip, sometimes over the chest, the belly button, inner part of the thighs and the back. And in addition to that, then variably some effect on occasion with respect to irregular or absent periods, what we term medically as oligo or amenorrhea. And there's various combinations that affect patients according to the severity or differences in presentation. So it's characterized clinically by hyperandrogenism, and what we mean by that is a raised testosterone or related hormones and or hirsutism, this hair growth in the male pattern, in addition to the menstrual disturbance, and of course at some stage for many women some difficulties with respect to fertility, or that's an element of the condition that we can treat quite effectively on many occasions. And for these reasons there's often a historical focus on reproductive outcomes. But PCOS is now recognized as a disorder which extends beyond the ovary. It's a disorder characterized very much by reduced responsiveness of the body to insulin, what we term insulin resistance, as we see in patients with type 2 diabetes, in addition to what I've already described as hyperandrogenism or raised testosterone and abnormal ovarian appearance or morphology. And the question that I'm going to address first of all from some of our work is whether this translates therefore into other health risks, whether this does in fact lead to an increased risk of type 2 diabetes, as I've hinted at, and in turn whether that in fact increases the risk of cardiovascular disease. So to turn to this question, first of all, we've relied on what we call big data, so analysing large-scale data sets to try to address the risk of long-term adverse outcomes. And I'll introduce you first of all to one of these data sets that we've turned to, which is called the Clinical Practice Research Data Link, or CPRD, which for those of you who aren't familiar is a primary care data source available to researchers within the UK. The advantage of this is that in an anonymized manner, we're able to analyze data of over 16 million active patients currently, with data accessible to us, including demographics of the patients, recorded diagnoses, prescriptions, and other health service contacts. And in the first of these studies, we applied a retrospective design, a look back, if you like, taking a large number of women with PCOS and matching them with control women, so non-PCOS women, by age, body mass index as a measure of weight, if you like, and primary care practice, or the region from which they've come from, with the aims to assess firstly the relative risks of type 2 diabetes, analysing 20,000 women with PCOS in that particular study, and 80,000 women who were controls or non-PCOS patients, and more recently then looking at the risk of cardiovascular events. And what we mean by that is actual events that present to the NHS, such as heart attacks, angina, strokes, and so on. And in that particular study, which was a larger study still, that was around 174,000 women with PCOS and 174,000 controls. So I'm going to take you through these data, these slides very carefully so that we can all understand what we're looking at. And what we're looking at here is the analysis, first of all, with respect in particular to the first study of 20,000 women with PCOS and 80,000 control patients, with respect to the risk of progression to a diagnosis of type 2 diabetes, shown in panel A, panel B, which is looking at the risk of cancer, panel C, looking at large vessel disease, and what I mean by that is cardiovascular disease, such as angina, strokes, and heart attacks, and then finally panel D, which is all-cause mortality or death for patients shown in black in the curves with PCOS, and then the control population is the one that we can see with the grey curves shown in these figures. And if we can look at panels B, C, and D, first of all, we can see that the curves actually overlap. There's no real difference. When we look at the x-axis, is the number of years from the index date, which is the date of the diagnosis by which PCOS was made, first of all, and a clear overlap with those curves. So no evidence of any difference with risk of progression to those outcome measures when we looked at it in this particular study. However, as we can see from panel A, those curves clearly diverge, such that by the end of follow-up in this particular study, which is around about 20 years from diagnosis, some 8% of our patients with PCOS had progressed to a diagnosis of type 2 diabetes, compared to around about 4 or 5% in the background or non-PCOS population. So a clear increased risk of type 2 diabetes. We were able to look into a bit more detail in this study as to what informed that risk of progression to type 2 diabetes, which is clearly important for us to understand. And what this chart shows is along the x-axis, along the bottom panel here, is we were able to characterize our patients at baseline at the time of diagnosis according to their body mass index into a normal body mass index or a healthy BMI, an overweight category in the middle here, and then on the far right, an obese category. And then we also looked at what their weight or BMI specifically was at year 2. And if we look, for example, at the normal BMI at baseline, if patients had progressed to being overweight or obese at year 2, the risk of a diagnosis of type 2 diabetes being made rose exponentially. And that was repeated across each of the weight categories. Conversely, we can see that patients who were obese with a baseline BMI, if they were able to reduce their weight into a better category of overweight or normal, they were able to reduce their risk of progression to a new diagnosis of type 2 diabetes. So this is quite informative data with respect to our clinical practice, emphasizing the importance of maintenance of a healthy weight, preventing the risk of progression to an adverse metabolic outcome. I did mention in the previous slides that the risk of large vessel disease, so angina, myocardial infarction or heart attacks, strokes and so on, wasn't particularly different in the original study with 20,000 women and 80,000 controls. So we've revisited these data more recently using a much larger sample size. This time, as I mentioned, over 170,000 women studied and 170,000 controls. And I'll take you through these panels again. So very similar curves. The lower panel here is years from index date in each of these graphs. So the years from diagnosis, if you like, with PCOS again shown in black, and in the gray is the controls or the non-PCOS women. We can see, for example, with respect to stroke shown in panel C, there were no particular differences, nor actually in mortality or death from cardiovascular event. But we did, however, find significant differences with respect to an increased risk in the PCOS group for in panel B, which is myocardial infarction or heart attacks, panel D here, angina, and panel E, which is revascularization. And what we mean by that is an increased need for procedures such as a stent or indeed coronary artery bypass grafting. And panel A at the top is a composite measure, a combination of all the outcomes, which again was significantly increased for the women with PCOS compared to controls. I say that it's increased, but it's noteworthy that we needed a very large number of people to study in order to demonstrate this. And it's an important reminder that although the relative risk is increased, the actual number of people at this young age, particularly in women, is a very, very low risk in absolute terms. So it's slightly greater than controls, but in terms of the actual number who go on to get an individual event, it's still very, very low. And again, as with our previous study, we were able to look at which particular factors from our analyses influence that risk of progression to a cardiovascular event. And weight gain again emerged as an important, potentially modifiable risk factor, in addition to a prior history of type 2 diabetes and social deprivation. We've also begun to think about what might be driving this. And one of our areas of interest is to look at brain imaging, particularly because of the strengths of Cardiff with respect to the Cardiff University Brain Research Imaging Centre, or CUBRIC, which is a major feather in the cap, really, of Cardiff University with respect to the types of analyses that we can do. I'm going to talk a little bit now about the sympathetic nervous system. Why do I want to focus on that? Well, the sympathetic nervous system, for those of you who aren't aware, is an automatic part of the nervous system that controls areas of our physiology, if you like, such as heart rate and blood pressure, unbeknown to us. And we can activate that in experimental terms, shown in the top right here with a hand grip exercise. So asking an individual to grip that to about 30% of their maximum contraction using something called isometric forearm contraction, and then activates the sympathetic nervous system. And we can measure that directly, as shown in the panel on the right-hand figure here at the bottom, where we insert a tiny microfilament into an accessible nerve called the common peroneal nerve, and we'll get a readout shown in the table with respect to burst frequency, so the actual amount of neuronal firing per minute, and then burst incidence, which is the amount of neurons, if you like, that are fired per 100 heartbeats. And we've been able to compare a group of women with PCOS and a group of control women matched for other factors. And we can see that before isometric forearm contraction, or pre-IFC, there was no differences between the groups. But after isometric forearm contraction, there was increased activity of the sympathetic nervous system, more so in the PCOS population than there was in the control population. What we then went on to do was to apply the exact identical experimental paradigm of this isometric forearm contraction, or this hand grip exercise, within an MRI scanner. And we're able to do something called bold fMRI. And what that means is blood oxygen level dependent functional MRI. So that gives us a readout. It gives us a signal change whenever we see any certain groups of neurons firing in response to this task. We can look at that in some detail to assign a function to that. And shown in the color charts here are areas which were significantly different in response to this exercise in the PCOS group compared to controls. And there's an area in particular that emerged as one of interest, and that's the right orbitofrontal cortex, which is an area that we know from other studies in other groups of patients is very important in blood pressure regulation. So for the first time, we're beginning to link some mechanisms in relation to potential cardiometabolic risk in women with PCOS that extends beyond the ovary, and using these advanced MRI techniques, beginning to understand where in the brain those sort of signals might arise. The question that then follows, of course, is whether we can actually reduce the risk of cardiovascular disease. And some of you will be very familiar with a tablet called metformin, which we use reasonably widely in patients with PCOS, although there's not that strong an evidence base yet for it. But it is used very widely in patients with type 2 diabetes because it improves insulin sensitivity. It also has a small beneficial effect on body weight and may in fact improve blood lipid or cholesterol levels. And we therefore asked the question whether it can improve markers of cardiovascular risk. And to address this, we use a gold standard clinical trial design. So it was a randomized study, so a computer-generated list deciding in which order patients would have treatment. Double blind, so neither ourselves as investigators nor the patients knew which treatment they were getting until the end of the study. Placebo-controlled or a dummy treatment given in sequence, as I'll demonstrate in a second. So, and then a crossover trial. So every patient had either metformin first, followed by the dummy treatment, or the dummy treatment first, followed by metformin. So a gold standard trial design to look at the effects of this drug treatment on vascular or blood vessel function and metabolic risk in young women with PCOS. And the technique that we looked to address the issue of vascular function or dysfunction was a technique called applanation tonometry. So as we can see in this figure on the top left, this involves a pencil-like probe placed over the surface of the wrist, over the radial artery in this instance, but we can also look at measuring over the carotid artery in the neck and the femoral artery in the leg. And it'll give us a readout shown in the bottom right panel here of a typical waveform, the pulse waveform from the radial artery, and using a validated mathematical function, we can get a derived central or aortic pressure waveform. We can also calculate what the central blood pressure is in addition to the blood pressure that we record over the arm as we would in a general practice surgery, for example. So this was a summary of the trial design that I briefly mentioned. This first treatment phase with 15 patients given metformin in a stepwise manner for the first 12 weeks, a washout, so getting the drug out of the system for 8 weeks, and then a crossover in that group to the dummy treatment for 12 weeks. And then the opposite group, group B, had the dummy treatment initially, a washout of that dummy treatment for 8 weeks, and then they crossed over to the active treatment or the metformin, with measurements made at the beginning and end of each treatment phase. And again, a little complex chart, but I'll take you through this table very carefully. So pulse wave velocity that we describe in the top part of this panel is broadly a technique which reflects the stiffness of arteries. So a minus reading is a beneficial response in this table. And this is looking at differences for when patients were taking a metformin compared to the placebo or dummy treatment. So there's a significant and beneficial reduction with respect to stiffness measures from the brachial and aortic pulse wave velocity, blood pressure, both systolic and diastolic, whether measured in the periphery at the level of the arm or centrally from the derived measurement that we could do, and quite significant differences in response to metformin compared to when they won just dummy treatment or placebo treatment. We couldn't, however, conclude that this was necessarily a direct effect of the metformin, because we were able to demonstrate also a subtle but clinically meaningful reduction in weight of around 2 kilograms in response to metformin compared to the dummy treatment. And that was also mirrored in a beneficial reduction in BMI or body mass index, fat percentage, and a reduction in waist circumference in particular. So the conclusions from the first part of this evening's presentations, I would suggest, are firstly that patients with PCOS seem to be at an increased risk of type 2 diabetes and cardiovascular events compared to non-PCOS patients. Some of these risks may be mediated centrally, in other words, within the brain. and can importantly be unmasked by major developments that we're seeing now with the use of advanced MRI techniques. And finally, the treatments which target weight loss and insulin sensitivity may hold promise in reducing the risk of cardiovascular and metabolic disease, but importantly, we need more data to address that in a bit more detail. So for the second part of this presentation, I'm now going to move on to mental health, because we know that PCOS clinically, when I see patients with PCOS in my clinical practice, I very much appreciate it as an under-recognized and underappreciated condition, which has a very significant impact on the lives of women affected. Not least because the skin manifestations, for example, of hyperandrogenism or raised testosterone, such as the hirsutism that I've mentioned, but also acne and scalp hair loss, can of course be very emotionally distressing. And these and other factors, such as concerns in relation to long-term health risks, such as concerns in relation to fertility and other issues, might of course contribute to an increased risk of depression and anxiety. More recently, however, there have been studies which have extended these observations to examine neurodevelopmental outcomes in children born to mothers with PCOS. This is an area of active interest at the moment because we know that androgen or testosterone levels tend to be slightly higher in PCOS pregnancies than in non-PCOS pregnancies. And many of you will appreciate that the classical neurodevelopmental disorders of ADHD or attention deficit hyperactivity disorder and autism spectrum disorder are more likely to be diagnosed in males than females, and not all of that is due to a referral bias. And with that background in mind, we turned again to CPRD, this large-scale data set that we're able to analyze data on quite a significant scale on. Firstly, to ask the question to establish the relative risks of major mental health outcomes in women with PCOS compared to matched non-PCOS controls. And secondly, to establish whether the risks of neurodevelopmental disorders, in particular ADHD and autism spectrum disorder, in children born to mothers with PCOS were altered in any way compared to matched controls. And you'll be familiar by now with these curves, these charts, these figures. I don't want you to concentrate too much on what I've got at the top there in terms of control set 1 and control set 2. Those details are beyond the level of detail that we require in this presentation, but broadly we're looking in the top panels at the time to depression, and in the bottom panels at time to anxiety, followed up prospectively over time. And again, the black curve relates to the PCOS population and the grey to the non-PCOS or control population. And it's evident, of course, just from visual inspection that the risk to a diagnosis of depression is increased in women with PCOS, and in the bottom panels also a risk of a new diagnosis of anxiety recorded in the notes is also increased in patients with PCOS compared to controls. Then we looked at the neurodevelopmental disorders in the offspring. So we're looking in this table at the top here in relation to a diagnosis of autism and ADHD. And the odds ratios here are significant. What we mean by that the risk is slightly increased in children born to mothers with PCOS compared to non-PCOS mothers. What I want to emphasize, however, is the actual risk. So although we've said that relative risk is slightly increased for this study, the actual risk, the number of people affected, the number of children affected is very, very low in the general population. And I think that's a really important message that we take from this presentation, is certainly something that if it ever arises in clinical consultations, that we're keen to reassure that the absolute risk is very, very low. But it's intriguing and merits further consideration. And the question we've therefore began to consider is whether this is due to increased androgen or testosterone exposure during pregnancy, for example, or alternative explanations might be that there could be shared familial factors between PCOS and psychiatric disorders that could exist, including a common genetic predisposition, as well as shared psychosocial factors in childhood. And before I come to the conclusion of this presentation, I'll leave you with some other data that's begun to think about this in a bit more detail. Here are some data that we've taken from 19 adult women with PCOS and 19 matched controls using a different type of MRI technique also conducted in Kubrick called diffusion tensor MRI, which is a form of structural MRI, if you like, looking at the structure of the white matter. So broadly, there are grey matter and white matter within the brain. And we've used this technique to look to see if there's any differences that we can see in adult women with PCOS with respect to the white matter integrity. We can see from the panel here, these are basically maps of the white matter skeleton in this instance showing something called axial diffusivity, which is a technical measure of white matter integrity, if you like, which in the blue here shows group differences between the PCOS population and controls. So we were able to see some subtle differences. And again, when we looked at that in a bit more detail, what we were able to do is to look at the relationship between testosterone levels in the patients with PCOS as a measure of androgen levels, so that sort of the testosterone type hormones in general, and correlate that sort of with what we call microstructural measures. So looking at the measurements within signal areas within the brain in a bit more detail. And if you look at the right-hand side of this panel, there's a relationship that we were able to demonstrate within an area of the brain called the corpus callosum, which is intriguing and merits further review, particularly I think with respect to an earlier age population when PCOS begins to emerge in adolescence, for example. So with that in mind, I think I'll bring my talk to a conclusion now with the following suggestions, really. First of all, that women with PCOS appear to be at an increased risk of type 2 diabetes, cardiovascular events, although I've shown you that the actual risk of that is quite low, and mental health disorders. I've shown you data for depression and anxiety. We also found a slightly increased risk of bipolar disorder and eating disorder generally as a category, but most likely to be related to binge eating disorder, which is what other studies have demonstrated. I've showed you promising results that drugs targeting weight loss and insulin sensitivity may hold promise in reducing the risk of type 2 diabetes and cardiovascular disease, and who knows, may also improve some of the other component measures such as mental health, but that remains to be determined at the moment. We've got a suggestion that children born to mothers with PCOS may be at an increased risk of a diagnosis of ADHD and autism spectrum disorder, but to emphasize my earlier point, the absolute risk, the number of people affected, is still very, very low. And I think finally, I think we need further research to understand the mechanisms involved in order to optimize interventions to reduce cardiovascular, metabolic, and psychiatric morbidity. And with those thoughts in mind, I'd like to thank my collaborators over the years and all my funders, including particularly the Waterloo Foundation, which are an important local charity, which has been very, very generous indeed in supporting some of our current research in relation to exercise and brain function. And we look forward to reporting those results in due course. Many thanks indeed for your attention. I look forward to some discussion. Thank you very much.
Many thanks, Aled, for that profile of a condition that affects so many women, with all the accompanying risks and consequences that you've outlined there, and also a fascinating area of research that's pledged to mitigate these. I'd now like to open the question and answer session. If you haven't already done so, the questions are streaming in. If you still want to submit a question, please input it, as I said earlier, at the bottom of the screen. And I'll start, Aled, if I may, with a question submitted in advance and then get to the raft of questions that are coming in. It's to do with the pill. The pill still seems to be the go-to treatment relied on by GPs for PCOS. Are there any other treatments that are more effective?
Yeah, so there's very few head-to-head comparisons, and the way that we approach a decision is very much according to what the patient's primary problems are. So I illustrated earlier in the presentation, I think, that the spectrum of presentation is variable. So, for example, for some women, fertility is an immediate concern, and the approach there that's taken is going to be very different and clearly not related to the pill. And in fact, there's a large-scale trial ongoing in the UK looking at the best treatment for fertility in PCOS at the moment that I'm happy to be chair of the steering committee for that. In a younger patient who has no immediate desire for pregnancy, the pill can be an effective treatment for the hair growth aspect, although it can take a long time sometimes for that to realize its benefit, in addition to regularizing the menstrual cycle. There are other treatments, so people do use metformin, although, as I mentioned, I think in passing, the evidence base is not that strong yet for how effective it is in many of the clinical components that we and patients worry about. And then there are second-line agents that we sometimes use to help reduce the testosterone levels, but those have to be chosen very carefully because the side effect profile is a little bit more significant, particularly if it was inadvertently given during pregnancy. And then finally, the thing I would emphasize is, the importance of weight loss. That in itself can have quite significant benefits with respect to things like the hair growth and menstrual regularity. And some treatments which are non-pharmacological, which unfortunately are very patchy in terms of availability on the NHS, but things like laser treatment and so on can be quite effective in some women for hair growth and so on. So lots of treatment available, and it's important that patients have an opportunity to discuss those with GPs and or specialists as required.
Okay, thanks. I had lots of questions about lifestyle. You touched on it there. In what guidance can one issue regarding diet, for example, exercise, the things that we do to guard ourselves against so many things, but specifically the risks of PCOS? What's the advice?
Yeah, so I think that's a really important question, and an under-researched area in general. There are international try to appraise the evidence with some recommendations in this regard some 3 years ago now, originating from Melbourne, and in a nutshell, there's no specific macronutrient diet that's recommended. So people have tried lots of different types of diet, but the evidence base is such that there's not particular evidence that one is more effective than another in the long term. My approach is to try and adopt a diet that's healthy, reduce calorie intake, with a modest target of weight loss of around about 5% for someone who's overweight or obese over around a 6-month period. Something that's achievable in the long term is going to be important in order to sustain that. Around exercise, again, there's a little bit of uncertainty as to what type of exercise is most effective, and it's perhaps timely to mention an active study that we have on the go at the moment, looking at a comparison of high intensity interval training or HIIT training versus moderate intensity or more standard exercise, if you like, given as acute treatments, if you like, looking at a variety of outcome measures, including questionnaires related to quality of life, including exercise ability of the patient, and also relation to sort of some of the MRI scan techniques that we've looked at. And that's an ongoing study that we have put on in a few years to address that in a bit more detail.
That's really practically helpful. Yeah. A question around hereditariness. Is it hereditary, or can one increase one's risk of having the condition through various, let's say, negative lifestyle choices, to put it like that?
Yeah, that's a really important question as well, and very relevant. There's a big international PCOS genomics consortium that I'm part of that's led from the States, looking at the genetics of PCOS in a bit more detail. It's a bit like type 2 diabetes. So for those of you who are familiar with that, it's what we call a polygenic disorder. What we mean by that, there's no single gene that has a big influence on the risk of developing the condition. It's a combination of many genes acting in concert in addition to environmental factors. So it's not a classic genetic condition per se, but if you have a family member with PCOS, or importantly, if you've got a family member with type 2 diabetes, that's something that we often ask for in the history that we take from patients clinically, because we know that potentially increases the risk a little bit, but it's not an absolute, if you like. In terms of modifiable risk factors, there's no doubt in my mind, not only from our research, but from the work of others, that weight gain can modify that risk. And that's something that can be done, if you like, to sort of try and reduce that risk of either getting a diagnosis in the first instance or progressing to a diagnosis or some of the other outcomes that we've discussed.
Okay. Question about different ethnic groups. Often the casualty, our knowledge of this, a casualty of not having the data, but do we know whether it's more or less common within particular ethnic groups or not?
Yeah, it does vary, and there's lots of studies that have been done on this. What appears to happen, a bit like type 2 diabetes, certainly with respect to the risks of longer term consequences, especially with relation to risk of progression to type 2 diabetes, is that risk is probably increased at a slightly lower threshold of weight excess for some populations, Southeast Asians compared to Caucasians, for example. What does seem to be apparent, though, is that the risk of actual PCOS per se seems to be fairly consistent across most population study when that's been looked at across the world.
Okay, interesting. Some lived experience questions here. Why does it take so long to get a diagnosis? And the perception that certain GPs are perhaps not as up to speed with A, the condition, B, how to mitigate, treat it, as one would perhaps expect or hope? And then a related question, is there a reason why blood tests seem to fail to identify it very often?
I didn't quite catch the second question, Damien. Do you mind just repeating that one? Sorry.
Yeah, sure. Is there a reason why blood tests often seem to fail to pick it up immediately?
Okay, so I'll address that one first of all then. So there's no magic bullet sort of blood test that's available to sort of say you have PCOS or somebody doesn't. And the diagnosis is usually made by a combination of the history taking, so what we glean from the story that the patient tells us, and is supported by some biochemical tests that can support the diagnosis, and on occasion an ultrasound scan, although that's not absolutely required for every sort of single patient. There is a blood test called AMH, or anti-Müllerian hormone, which is emerging as a biomarker that might be of interest in time, but the international guidelines that I mentioned don't quite state that as being sufficient evidence at the moment to warrant a major place in terms of diagnosis. But that's an area of interest. Many groups are beginning to look as a particular biomarker. With respect to delay in diagnosis, I think, I do see that. And, it's a pity that it can take some time, especially because it is quite a common disorder. I think what my reflection on PCOS is that, unfortunately, it tends to sometimes fall between many stools. So there's no overall integration of care. There's no particular specialty that takes ownership of this. And, patients can be referred to us in endocrinology, for example, depending on the presentation. They may be referred to dermatology. They may end up with gynecology or fertility services. And it's often the case, not just locally, but elsewhere in the UK and further afield, that because of that, there's no overall joined up sort of thinking, and that's something I think that needs to be addressed within healthcare services generally. Okay,
thanks, Aled. I'm going to throw at you now some conditions and some phenomena, and ask you, and this comes from the questions that are coming thick and fast still. Ask you about the relation, what we know about the relation between XYZ and this condition.
Okay.
So, any links, and what are they if there are, between PCOS and rheumatoid arthritis?
None that I'm aware. It's difficult because they're both relatively common conditions, so sometimes it's not unexpected that people might have both in combination, but it's not something that I've come across.
Gallstones?
Only perhaps indirectly, because we know that being overweight or obese in its own right can be a risk factor for gallstones, and we see that 2/3 of our patients with PCOS tend to have problems with weight, so that's probably an indirect association through being overweight.
Slightly different category, birth weight.
Yeah, so people have looked at this. One of the, I guess, it might be slightly increased, but that's probably due to an increased risk of what we call gestational diabetes in pregnancy. So there is an increased risk of diabetes, as I've demonstrated, outside pregnancy, but it's also slightly increased during pregnancy. And that in itself can drive birth weight.
Okay, here's a contemporary one, COVID-19.
Yeah, so people have looked at this very recently. We haven't done any work ourselves on it, and people have suggested that it might be slightly increased. Again, it's difficult to know. So it's difficult to know whether that's again mediated through the weight problems or not.
Depression.
Was that, sorry, I didn't quite catch that, Amy.
Depression.
Yeah, so I think, as I've demonstrated from the earlier charts, that that does appear to be increased, and there may be many factors beyond that. One of the areas that we'd like to pursue is to see if there's a genetic overlap with that risk, and I think watch this space in years to come if we can see.
Interesting one as well, because as one of the contributors has pointed out, that's a vicious cycle in many ways. I mean, getting a diagnosis of this condition will obviously increase the depression that may or may not have been there in the first instance.
Yeah.
Okay. An interesting one, might PCOS be considered, as a small group is urging it should be, considered an intersex condition?
I think that's a really sort of contentious one. I wouldn't see it as an intersex disorder. The way that medically there's something called DSD, intersex disorder, and PCOS wouldn't fall into that group, but a very specific sort of group of disorders that we would consider clinically in that sort of group. Really.
Let me throw one word at you and see what your response is in relation to PCOS. Spearmint.
That's thrown me, that one, I must say. Spearmint, as in what we conventionally mean in terms of the spearmint. I don't know. Is there anything that needs to be expanded that can help me with that?
A potential treatment.
Oh, I see. Okay. If there have been studies, I'm not particularly aware of them. I suspect if it was of any significance, it would have made its way very prominently into the medical literature. So if anybody has come across that, which I suspect somebody may have done, I suspect that it's probably not been done at a scale that would, give us enough evidence at the moment to justify anything. There is a group of, on that note, there's a food supplement, I guess that's what it's classified as, a group of compounds called inositols, which can also improve insulin sensitivity, for which there's a lot of interest. And but again, we need a little bit more evidence around that. So that's something that's worth mentioning.
Okay, and I'm keeping an eye on the clock here. One or two final questions here. How is your research funded, and how might those who are listening to this get involved in any trials or further research on a practical level?
Well, a personal observation is that I think, unfortunately, it is a little bit of an underfunded area for such a common condition. We have had very generous support locally from the Waterloo Foundation, as I mentioned. You've seen some work from the last slide, colleagues, or some of my MD and PhD fellows have had support from the Royal College of Physicians. We've had some support from the British Heart Foundation for some of the vascular studies in the past. There isn't a condition-specific charity as such, but the well-being of women is one of the charities which can support, in addition to the more usual charities such as the Medical Research Council, the Wellcome Trust, and so on. And we do have a grant proposal in mind to the NIHR, or the National Institute for Health Research, for the HTA scheme later this year, looking at potential new therapies, in particular in relation to weight loss that we're very keen to pursue. People are very welcome to contact me if they've got interest in some of our studies. There are a couple of studies that we've got open at the moment. I mentioned the exercise one. There's also a UK one, of which we're one of the participating centres, looking at what we call the steroid metabolome, which is a new biomarker, if you like, trying to understand which patients are more likely to be at metabolic risk than others. And that's a relatively straightforward study, but has some tight criteria around it. But I'd be very happy to be approached around that if need be.
Okay, thanks, Aled. One final question, really, and if you could give me a swift answer to this, that would be appreciated. Where are you going next? What's the pathway and ambitions of your research?
Genetic overlap, looking at with mental health disorders, trying to understand what happens neurodevelopmentally in adolescents as they develop sort of PCOS, and then this weight loss drug, which looks to be very promising, that I'd like to explore for the first time in a large group of patients with PCOS on a large scale.
Diolch yn fawr iawn I ti, Aled. Dyna fe gyfeillion. Dyw amser ddim bellach o'n plaid ni yn anffodus. We're out of time, unfortunately, but Aled, thank you so much for joining us. And I also want to thank you, the audience, for being with us and for feeding us those questions. I hope you found it insightful. And if we didn't get a chance to answer your question, we will, I promise you, respond to each of them by email. Final couple of comments. As I said at the top of the event, you'll receive an email later this week with a copy of the recording and link to register for upcoming events. And I need to say something very swiftly about one of those. Next one, in fact, in this series, taking place Tuesday, 15th February, where Cardiff Business School's Professor Emmanuel Bonner, he'll be outlining the strategies he's developed through which we can have a chance to dismantle that intolerance. And if anybody watching would like to get involved with Cardiff University, Aled said something about that just now, I know. Volunteering time to help our students, help us fundraise for any aspect of our research, in the comments box that is available right now. So thank you so much. Do look after yourselves. Diolch o galon I chi a gofalwch ar eich olech hunan. Nos da. Good night. Many thanks.